Well, I think we're going to get started. I think it's a fairly intimate group here, end of the day session. That's terrific. I'm really thrilled to be able to speak with you today on a very timely topic. Really, coordinating person-centered care is a key initiative right now in the NHS. How it plays into patient flow and how it ultimately is something that is going to help us all collectively deliver against the outcomes that we need from a patient-centric standpoint and from an NHS perspective overall is what I'll spend the next 20 minutes or so talking on. One slide on Strata Health very quickly. We're a Canadian and a UK-based company, number one. Number two, we have been focused on coordinating care across integrated healthcare regions for 12 years. That is all we do. We've had clinical guidance from the UK, from Canada, from Australia, right across the Commonwealth. And then lastly, we manage about 11 million lives overall between the UK and Canada. So there's some breadth of knowledge there. What I'd like to do is talk about today's syllabus, if you will, and the picture connotates a little bit of perhaps confusion or frustration. So I'm going to narrow it down and keep it fairly light, but 4 key topics, if you will, are points of discussion for the group. Number 1, it's not okay. I'll explain that in a second. Number 2, what if we could? Number 3, absolutely yes we can, and number 4, here's how. So if I can progress on that, I'll keep it light, I'll keep it moving for the next 20 minutes, and then we can break for drinks soon after. A bonus topic for all of us as well is that, and I'm coining this phrase, it's patient discharge is a bit of a dirty word, and I'll tell you why and why I'm saying that as we go on as well. So let's start with integrated care. And really what we're talking about, as we see here now, under 175 definitions, whittled down to 1, is person-centered coordinated care. That's a mouthful. We'll refer to it as integrated care, but it really comes down to people who work together and coordinate services for me as a patient. That's in many ways the holy grail right now for the NHS and for local authorities. We need to deliver better patient outcomes with limited resources, and that's going to take us a long way in getting there. It's not a new topic by any means. If you go back 2 or 3 years, Kelly and Ham have talked about integrated care in a macro, meso, and micro level. There's lots of documentation on it. But I think, and I agree with this perspective, that some feel that in the past integration has been focused a lot on structural change. And today, I think what we need to do is focus on the patient and what it means for the patient moving through the system. And what we define the system is. Is it just health? Is it social care? Is it volunteer services? Is it the whole array across the continuum of care? Now, I was lucky enough to see Mr. Ricketts speak a couple of weeks ago at London's College of Physicians, and care coordination was on his top 10. So unequivocally, it is one of the big topics in today's environment. Yet, and this is the big reveal, hot off the press, and you might have seen it from last week, 93% of the industry leaders surveyed through Confed have made no significant progress to date. And here comes my first point. That's not okay. That's not okay from a patient standpoint. That's not okay from a system standpoint. That's not okay for the longevity of delivering healthcare within England. It gets better or worse, depending on how you look at it. Additionally, most think that if we fail to deliver this, the result will be unsustainable services, poor quality patient outcomes, and a decreased quality of care. So this is critical. We have to get this right. That statement is not right either. It's not okay, hence my graphic here. None of this is okay, but what if we could make some, wait for it, progress? Okay, how do we do that? So progress defined not in terms of 2018, years beyond, consultations, talking about it, but real live progress that says, right, we're going to do what we say and we're going to deliver some outcomes against this. Well, you don't have to look very far. NHS England has some great reference points that make a ton of sense to me and likely to you as well. They're talking about things that are requiring a pivotal change for the NHS and delivering key patient outcomes and reducing waste. They go on to say that there are 5 simple steps, and this is absolutely right from 35,000 feet up. You start with building relationships, you analyze, you design pathways, you specify and you deliver. Okay, that's terrific. They go on to say leadership has to happen from at the top. So CCGs have to take that decisive step forward and move on, but it's going to be delivered at the ground up. It's going to be delivered on the front lines, and therein lies the key. And I'm going to talk a little bit more about that as well, because a 40,000-foot view across a national program isn't going to work when you try and deploy it at a granular level. That's as granular as it gets, is this slide here from those 5 steps. When you step into a region, it gets a lot more detailed. And here's a neat fact that I wasn't aware of until I started researching a little bit on this presentation, but this is fundamental big change. And in anticipation of this, there was a mission that was sent to Canada last year about this time. And they went to British Columbia and they talked to the Ministry of Health in British Columbia. And they said, right, how have you been so successful across integrated care and coordinating patients' journey and patient flow? And they pulled the learnings back from that mission, and they've got it again as a reference point, some really key learnings in a toolkit to help us move this through. The reality is, here in the NHS, here in England right now, here in healthcare and social care, we're not the first ones to have to tackle this problem, and we won't be the last either. So let's draw on some of this information. A star for anybody out there that might hazard a guess on who in Canada helped BC and ergo Western Canada with a lot of their integration and is pivotal within that in terms of coordinating care. Any guesses? Strata Health, there you go. Yeah, you're right. So, little plug there. But here's an illustration that came out, and it's interesting. Illustrations are pretty popular now, and I started to try and decipher this in terms of key learnings from the summit. And really, I was seeking to answer the question, well, what's creating difficulty in getting progression, and getting that progress that we need here and now in the NHS? And so I started to look a little deeper, and then I started to look a little deeper again, and then it hit me far off in the corner of the illustration, and it said, coordinating care is difficult, complex, and it's a full-time job. Yeah. Okay, well, that makes sense. And you can even see for the flow-charted hardy people that like diagrams there, care coordination in the middle wrapped around services. But if that's the excuse, I've got to say that that's not okay either. What if we could get some progress? And absolutely, yes, we can. So how do we do that? Yes, we can. Well, back to the King's Fund, they're talking about the right patient at the right place at the right time, and they're calling on innovation to help us there. So we do have to lean on innovation, and I think technology is going to play a part in that as well. Now, have you ever heard of this guy? If you haven't, you certainly will soon. Amongst other things, he, to some, is known as the forefather of patient flow as well, globally. And a lot of the principles that Strata Health uses over the last 12 years in patient flow and coordinating care are based on the work that he had done, Don Berwick, in IHI. And it talks about patient flow, and we've seen patient flow, but primarily through the hospitals, through the acute centers. And this is where that reference to discharge becomes a bit of a dirty word, because at the end of an intervention, patients get discharged and moved out, and they're over to you, I'm done with Joe Bloggs, he's discharged. But the reality is that they don't get discharged from the system. They move through the system and they get a transition to another level and location of care. So if we look at that philosophy, and part of Berwick's philosophy of system-wide coordinated care through patient flow, We need to look at engaging the CCGs, looking at the local authorities as part of the resource base, community services, volunteer services. Everyone has a role to play within the resources across health and social care. What's more is if you start to say that, you start to say, well, the continuum of care isn't just health or health and social care or health and social care and volunteer services, but it's the entire array that we need to leverage to really make a difference. It starts to say, well, how do you expect a clinician then who's on the front line in a pressurized environment to be able to have all of those reference points to hand and make that right decision to make that referral to that endpoint? Matching capacity and demand and reducing variation is key. And so we're going to talk a little bit about that as well. It talks then about system-wide coordinated care, looking at resource matching, that's a key word, capacity, but not capacity in terms of, I'm a service, it's Friday afternoon, I'm feeling a little bit like I'd like to take a long weekend, so I'm going to be red today. No, it's actual resource capacity and what that looks like. Pushing and pulling patients into available resource downstream, status intervals, messaging, thresholds, all driving key performance indicators. So that's a lot of key information that will get to system collaboration. That would be okay if we could get there, and we can, and now I'm going to tell you here's how. Delivering person-centered coordinated care requires moving patients between services. So those lines there, linking up the patient in the middle with just about any kind of care resource that you could imagine across that continuum. Now, if we empathize with those on the front line, we step into that role and we look at a nurse, triage nurse, someone's come into A&E or an MAU, and they say, right, well, you really don't need to be here, but we need to find something else for you downstream. A lot of times that is, well, what's safe, what's available, and hopefully what's best for the system, best for the patient as well, obviously. It's tough though, because clinicians may have 5, 6, 7 different referral routes that they can use. Community services, phoning around, trying to find the right level and location of care, or sometimes it's a step-down safe hospital bed, but probably isn't the right use of that resource as well. What if it's health visiting, assisted living, mental health, bereavement, counseling, socialization? Minister Lamb's example this morning, if you caught the keynote opening, where he talked about the individual that was degrading significantly in the community, but what he needed to do was be re-socialized in and have a purpose, a greater purpose, and the effect that would have on his overall health was profound. That's really what we need to do in terms of broadening the resource base across health and social care. Now, system-wide coordinated care. From a systematic standpoint, historically, we've seen some great strides. And on the left, you'll see a map of urgent care within an existing NHS trust that we're working with. And they're buttoned down relative to systematic integration. Their vision now, and I'll make pull no punches. I mean, this is Cumbria. Their vision now is to move from a system that, whilst is very robust from an integrated standpoint and a systems standpoint, structural integration, moving to a system that's easily navigated by the patient and frontline carers as well. So you move over to pictorially the picture on the right, and it tends to say 1,000 words. What you need to do then is look at underpinning some of those principles, which says they need to be very specific in terms of patient need and commissioned service, and you need a system, some sort of system, to underpin matching and e-referral, patient need to commissioning resource. You need to look at capacity across all of those different care types, real capacity in terms of whether it's a bedded facility or whether it's queuing theory, looking at throughput of a service and saying, well, you've got an option to do a referral to district nurse team A, district nurse team B, and a variety of compiled services under a package of care that looks like a group out of social care and someone else over here. Because those type of interventions will service Joe Bloggs' need over here. You can't expect someone on the front lines to have that information to hand in a pressurized environment. We need to make it easy for them to have that information at their fingertips and then move that referral on. And that's key. And that only happens at the local level, because integrated care in one health jurisdiction is going to mean something different than integrated care at another. And MSK in one of our clients has 3 different meanings, depending on where in the system you're targeting that intervention. And then finally, a system, and I'm saying technology plays a part in this, that looks at meaningful analytics. And these are analytics that aren't, a nice dashboard that, looks at long-term trends, something you take to your board meeting every month. That's important, but let's have some real-time, on-the-ground information that looks at acceptance and rejection at the point of acceptance and rejection. Looking at response times, looking at thresholds, breaches, unmatched service needs, pointing to gaps in the system, and even looking at costs in real time for a real-time modus operandi. So back to flowcharts just for one slide, and for those that like flowcharts, it actually looks a lot like the illustration that we put up about 10 slides ago. But in the middle, we've got resource matching and e-referral, and really giving people anywhere in the continuum for a designated region access to services that are on the system. And it's a dynamic directory of service that lives and breathes and changes day by day, hour by hour. And I mean that because as soon as you think you've got a hard copy that's good, it's like reading an old newspaper. It's outdated because something's going to change. Then you look at dashboards from senders and receivers, early notifications and wait lists. You've got to make it easy for the operational group that's using the system, and it's got to come from them. If it does, it'll get bedded in and it'll get used. You look at agreed admission criteria bespoke to local services. This is the magic point right here. It's tough though, because again, at 40,000 feet, you can go and say there's 5 key points to integrated care and coordinating it across the NHS. You take that to a granular level and you say, right, you go to each service across a region and you say, right, what are your access criteria? And so they'll tell you, and then you go to the senders and you say, do you agree with this? And you have to make sure that those 2 things, everyone is on the same page. And if you do, the referrals will flow and people will use the system. And if you don't, they won't. Matching criteria capacity, time intervals, and transactional process of the patient handoff. So marching those individual patients, mobilizing them from one level and location of care to another. Not discharge, because remember, that's a bit of a dirty word. The only time you're truly discharged is when you're 6 feet under the ground, but transitioning through the system, even if it's home. If it's home, let's look at minimizing or reducing or eradicating their return to acute as well, right? So let's really look at focusing that. Dr. Lum in Cumbria likens it to the air traffic control system for Cumbria, and it's our latest implementation. It's region-wide. It's over the course of probably 24 months, but we're rapidly underway right now. We've deployed for acute referrals outbound into social services, and we're really excited about it. If you think of air traffic control, it's a great analogy, and it starts to look at how coordinating patients across a system might seem to make sense. A couple of screenshots here I'm not going to get into, just relative to the fact that it's a real system. It's developed by clinicians, for clinicians. It's easy to use, and people smile when they use it because they like it, and they like it because they use it, and it helps their job from a day-to-day perspective, and it helps them help the patient, which is key. Lots of nice dashboards, again, not going to go through them in detail, but looks at KPIs overall from an executive standpoint in real time, looking at overall volumes to see gaps, looking at declinations of referrals to say, well, where are the gaps in service and how do I commission ahead of the curve, and how do we progress forward? So that's the how from my perspective. But back to reality. Let's step back a little bit now and look at what's next. Quite frankly, then what's first, because we're in a situation where we've got the Francis report, we've got huge pressures on patient safety that we've got to deal with. That is priority one. And on the other side, we've got 20 billion pounds in savings to make as NHS England. So it's a tough place to be in, and we hear that time and time again. Well, my recommendation is, if that's the elephant in the room, we might not be able to get that elephant to dance all in one go at the first go. We might have to take it in stages. But you've got to take a decision to move forward, and you've got to look at the things that are out there in terms of reference to people who've done this before, reference to NHS England, and some of the things in terms of case studies that have actually worked in the past, and then bring it back home to a regional level, to your CCG, to your local practice, and say, well, what works for us? Because all that is good, but we're unique, our patients are unique, our needs are unique, our commissioning services are unique as well. If we do that, we can take that decision. And if we take that decision to move forward based on, again, leadership overall, well, that's progress. And that's really important. All I can tell you from my perspective is some of the progress that we've seen over the last 12 years. And I'll move through this really quickly, but large health regions in Canada, millions of people in a fully integrated system at any point in time, patients waiting in acute, 100 patients at any given time, over the span of a number of years, all the way down to 20 patients, 2% of overall acute beds and delayed discharges, some of the best in the country, and it stays there today, 12 years after. Another region, Capital Health, 2 million people, under their own penmanship, 400% reduction in wait times in continuing health care. I didn't write it, they did. That's their reference, and it's reference to Strata pathways. Closer to home in the NHS, we've done some wonderful things in Rotherham, really meaningful things, saving bed days, and we've done it by some pretty simple things in the early days back 3 years ago. Half of the referrals that went through went into the ether. They didn't meet their mark. They were paper-based. They either got jammed in the fax or were illegible or something happened otherwise. We know paper's not good, but if you take away even that simple low-hanging fruit, we've gotten to a point where we're 4% of referrals that are rejected at any given time, and those 4%, we go through them and say, well, what are the reasons why? Well, there's some really good reasons. The patient died, or the patient was discharged home and the family's looking after them now, a happier scenario. We moved on to the local authority there, and we looked at intermediate care beds, and they were struggling for getting full occupancy based on quality referrals for people that needed reablement. Well, that quickly went to 100% when we got the right person in the right care at the right time. And we went from 2 months turning of beds in intermediate care to 2 weeks, which was the goal. That's some good stuff. Again, it's simple stuff, but you have to get hands-on at the granular level to make it happen. We had similar scenarios within Buckinghamshire, and we're working hard within there and seeing some outstanding results. And I'm more of a pictures guy, but pictures say 1,000 words. And here's one where it's social care in the front and health care in the back. And they're smiling. And they're smiling because their life got a little bit better at work, and they're seeing outcomes from patients getting better, and they're happy. And it's their system. We've helped support them, but it's their system, and we've enabled them to move it forward. We've seen underpinning local best practice in Bucks, same thing. People believe in the system, it gets bedded in because it's their system, and they've helped guide us there. Coordinating care across organization. RIA coordinates end-of-life clients out of the hospital into more appropriate areas for them to pass. It makes a difference in her job, and her success rate in doing that has gone way up, and that's a good thing. And teammanship, building across that teammanship has really increased across deployments. And finally, supporting clinicians on the ground. This is our latest deployment up in Cumbria. And Jane is smiling because, again, she says, you know what, this is pretty easy to use, and I'll tell you, it works, and it works because we took the time to understand what the clinicians need to help their patients. I'll leave you with 2 last thoughts. One, it's a long-term play. We need to start now, or else we'll get rolled over by the 20 billion pound challenge. And resource matching and e-referral perhaps is a good idea that has come to time within the NHS. What I'd like to do within the last 5 minutes is play a 2-minute video for you. It's from Rotherham, and it was an unsolicited video that they gave to me in support of the Integrated Care Awards that we're jointly being nominated for.
I'm Business and Service Manager for Trauma and Orthopaedics. We're looking to integrate our services along pathways based on patient need. The introduction of Strata has greatly facilitated and improved communication between hospital and community-based therapists and nurses. This has led to better plans of care for patients, earlier discharge from hospital, and an improvement in the length of stay for our patients.
I was introduced to the Strata system whilst I was working as a case manager in the local hospital. I worked on all types of wards, both medical and orthopaedic. I instantly saw the potential in the system for improving communication between the MDT and how it would speed up referrals between departments. I ended up sharing the lead for the rollout of the system, and it was my responsibility to teach all the staff who were going to use the system, such as the physios, the OTs, the musculoskeletal staff, anyone really. We found that Strata is a simple and easy tool to use. It's a safe storage mechanism for all your records, and because it keeps records, any subsequent referrals that you make are often made easier because all the compulsory fields are already filled in. Each service, each department can tailor make its own referral form, and this, as I said before, includes compulsory fields, so this makes the quality of the referral better. There is other features. The dashboard, for instance, enables anyone who is coordinating a service to see what status a referral is at, whether it's been accepted or denied, and therefore this person can act quickly and rectify any problems. We also found that Strata, again, because it keeps a good record, you've got a good audit system, and it can also solve disputes in that if someone says that they've referred to you, you've got a record in front of you.
We've used Strata as a referral to the acute musculoskeletal inpatient OT and physiotherapy service for the last 3 years. The results of using Strata as a referral system have been to enable nursing staff to refer to us 24 hours a day, being able to refer to us when it suits them, not when we're available. It provides an audit trail of the referrals and the access times it's taken for us to see patients. And as a result, the successes we had within referrals to inpatients, we've extended this to cover intermediate care referrals and subsequently domiciliary referrals as well. It's minimised the number of rejections that we've had in terms of those referrals to other services due to the mandatory fields that we've entered into the referral criteria, and it enables a smooth onward referral between services following that.
So that gives you a little bit of background in terms of Strata. I haven't left a lot of time for any questions, but if there is any questions, perhaps we have a minute or two. If not, I certainly thank you for your time. Yes, in the back? Oh, there's a mic there.
Could I ask, you've talked about the system.
Yes.
But was the system the single solution, or was there a lack of capacity also identified that actually there needed to be investment in community services in order that the system could actually transfer people through the pathway?
That's a good point, and at times it was a realignment of services, to be sure. So an example would be district nursing services in Rotherham. We rejigged them within our system, which meant that they rejigged them probably 3 times last year in terms of the shape and feel of how they looked after patients. But more directly, the system underpinned the local best practice. It was the change that was instilled by the frontline clinicians that said, right, here is how we need to work, that was the key and the magic, and the system then just underpins those and kind of acts as a lever to facilitate that, if it makes sense as well.
Okay, so with district nursing, for example, you may be accessing that as a pathway out of hospital, but you've obviously got the demands coming from primary care for the use of the district nursings. Would that all go through the same system?
Yes, and we've done this in a number of different ways. We've, in some areas, put in a single point of access where those referrals come into that point and then are put into the automated system and moved out. In other areas here in the NHS, we've piloted with local GP groups, and they love it because they don't have to get on the phone or they don't have to send through the fax. It's just immediately sent through, and then they can follow it up as well, which is nice. And it's something that we're actively doing in all care streams across Canada as well. Gentleman in the white, second row.
Thanks. Actually, two questions. I sat through a very boring NHS presentation earlier on about integrated care, and what I saw was a typical NHS structural plan for achieving that, and I've just seen the physical manifestation of how it can be developed. But the question is, how easy can you actually change a care commissioning group strategy in order to get Strata in to make it become a reality? The second question is actually around, so where does the business case get developed for using Strata? Who actually pays for it, and how does it work towards the 20 billion saving?
Okay, two great questions. Firstly, relative to making that change and getting it, up front to the board for ratification. I mean, we have found that it takes that leadership role and that one step forward to say, what is the art of the possible? And it can't be, an uneducated, maneuver, if you will. It needs to have some credence behind it. Ergo, we take the 12 years of this is what's been done, but as you get into different CCGs, they all have their own independent, challenges, if you will. And you get it. Cumbria is one CCG. In Northumbria, there's kind of 3 or 4 that need to kind of work within that group. It becomes even trickier, perhaps. But again, I think it comes down to that leadership at the top level to say, this is what we need to do towards integration, and then the ability to instill kind of the art of the possible down into those that are actually going to make the system work on the front lines. The second question relative to the business case, I mean, I think we incorporated here in the UK in 2008. I've been preaching the same message even before that, probably starting 2005. I formally moved over here in 2008. But, we look at, getting the key value proposition in a business case that says, look, if this is doable, so it is the art of the possible. You can actually deliver results rapidly, and rapidly is in months, not quarters or years. And there is a return on investment as well, because I know in this day and age, if something costs 3 beans, it better free up 6 beans at the end of the day, or the director of finance on the other side isn't going to give it his rubber or her rubber stamp of approval as well. From there, we've built a solid business case that we've initially put in front of foundation trusts, but we've quickly seen in the new NHS that it's the CCG, I think, that is the one that overall needs to kind of set out that leadership expectation of the overall group and start to break down some of this, even some of the tough barriers in terms of incentivization and payment, and say, well, but that doesn't really work because we're paid payment by results, and this. Well, then, there are CCGs out there that are saying, well, if we need to bend or break those rules, we will do that because here's the end goal, and that's big strategy, but it's impactful results at the end of the day. I hope I answered your question satisfactorily. Right. Okay. I think we're done. If there are any other questions, we're around in M32 for the rest of today and tomorrow. My name's Clint, and I'm around both those times as well. Thank you very much. Appreciate your